So in the last video, we talked about the importance of understanding the target communities from a social perspective. And in that video, we talked a little bit about a geographic understanding of the communities as well. In this video, I want to delve into the geographic understanding a bit more and talk about the geographic information systems for our malaria elimination project. So we work in Cayenne State, Myanmar, and this area has experienced a civil war for well over half of a century. During that period of time, there was no accurate census done in the area. There was no map pinpointing where villages existed in the area. So before we even began our malaria project, we needed to undertake geographic surveys. We wanted to know where communities were and roughly how big those communities are. And we need to have this information so that we have a baseline denominator. So the use of mapping in malaria projects is not new, but what is relatively new is the use of satellite systems for accuracy in those maps. We use global positioning systems, GPS, along with GIS surveys so that we can collect information about these places. We want to know roughly how many households are in a community, what the community is called, and exactly where the location of that community is. To get this information, we rely heavily on our community engagement team. Our community engagement team helps us select people from the communities that can then be taught to use a GPS unit and to fill out a geographic survey form. We send them out into the communities, they collect the information for us, and then they send the information back to us. When we get the GPS units and the forms back, we undergo a bunch of work, and after that is done, we wind up with a list. Essentially, the list is, for each row, it's one point, which is one village or one hamlet. We have the geographic coordinates, so the latitude, the longitude, the elevation, and then we have some attribute information. So the name of the village, whether or not there are health facilities already in the village, what those health facilities are capable of, and some information about communication systems. So for example, we want to know whether or not you can use a cell phone in the community. In many places in Karen State, you cannot use cell phones. Okay, from this list that we've generated from the geographic survey data, we can begin to create a geographic information system. At the most basic level, what this means is that we assign an identification code to each row in our data set, to each point that exists in our data set. This identification code is actually arbitrary to some extent, with the exception that it must be unique for each point. So for example, if we have a village named Ta, we may give it the identification code TO, that's for Ta, and then 0698. The actual number doesn't have a whole lot of meaning behind it, except that no other point in our data set, no other village in our data set will wind up with that identification code. After we have this identification code system set up, we can link everything based on that. We can map everything out, and the information that we collect can be analyzed in a spatial way. So for example, in our map, perhaps we want to see if there are large regions where there are no existing health facilities or where communications aren't currently available. And then we can begin to devise plans for how to get health care systems into those regions. So there are two major components to our malaria elimination project. One is a system of community-based health clinics, and another is the mass drug administration. At the community-based healthcare facilities, we require weekly data to come back. So a villager is trained to diagnose and treat people, and each week they record the number of people who come to a malaria post who were sick, the number of people who were diagnosed, and the number of people who were treated. Each week this data comes back to us. In some parts of our target area, there are no cell phone services, there's no internet, and there may not even be electricity. What this means is that we actually have paper forms that are coming back. People are carrying these in backpacks, they're coming on rivers or on motorbikes. At the top of each of these forms is an identification number. This is the number from our geographic information system. And using this number, we can link it back to those malaria posts and exactly where they are on the map. In other places, we've been able to set up a SMS system for receiving this data. That is, we've distributed a set of smartphones to malaria posts. People enter the weekly data there, and they can just text the data back to us at our headquarters. In both cases, though, the data are linked using this identification code in our geographic information system, and we're able to monitor the stocks in malaria posts and the caseloads in the malaria posts. For the mass drug administration, we began with an understanding that some communities in our target population had really high levels of asymptomatic malaria. These are people who do not feel sick, but they do have parasites in their blood. And they would not go to a malaria post because they don't have symptoms. We worry about these communities because they may be important reservoirs for transmission of malaria. We did not know exactly the distribution of these people across the landscape, though, or these communities across the landscape. So we started with our geographic information system, with the map, and we randomly selected villages to test for this. So we literally used a random number generator and the identification code system to randomly select villages throughout our target community, and then we sent our survey teams out to those target communities to collect blood to be tested for malaria parasites. When we find an abnormally high proportion of people in a community with these asymptomatic malaria, then we consider the community a hotspot and we begin a mass drug administration in that area. We also begin an adaptive sampling strategy around that community, though. So instead of just continuing the random sampling, we look around the community to see if there are clusters of hotspots of asymptomatic malaria in a certain area.